Okay, we're going live on Facebook now, hopefully, if everything works. Okay. It's preparing to live stream. So let's see here. Okay. I see people have logged in, some of them. Let's see. So hello, everybody who has joined us. Welcome to a new season of Excellence in Biology lectures by the Cyprus Biological Society. It's a pleasure to have you with us today. So we have the honor of having today Dr. Marcia Waddington-Cruz and Dr. Elena Zamba Papanicolaou to talk about hereditary amyloid polyneuropathy. It's a very sensitive subject, and I am very honored that both of them will be participating in this lecture today because they're experts and they're going to give us the best insights on what's going on in terms of treatment, what's going on in Cyprus for our patients, and in Brazil and in general for the landscape of amyloid polyneuropathy. So without delaying the lecture, I'm going to give a very brief introduction to Dr. Elena Zamba Papanicolaou and Dr. Marcia Waddington-Cruz, and then I'm going to give the floor to our wonderful lecturers. So Dr. Elena Zamba Papanicolaou attended medical school at Ioannina University in Greece. She then went on to complete her residency in neurology at the National University of Athens. And in 1997, she was a neuromuscular fellow at SING. She's currently the senior consultant neurologist and head of the Neuroepidemiology department and DMG laboratory at the Cyprus Institute of Neurology and Genetics. She is also an associate professor, which gives lectures to master and PhD students at the Cyprus Institute of Neurology. So now Dr. Marcia Waddington-Cruz, she has a very long resume. She graduated the medical school at the Federal University of Rio de Janeiro, and she holds a master's and a PhD degree in neurology, and she's also a certified clinical neurophysiologist. She was in charge of the neuromuscular unit at the University Hospital of the Federal University of Rio de Janeiro in Brazil, and she's also responsible for the Brazilian National Referral Center for TTR-related amyloidosis since 1989. This center, CEPARM, was the first amyloidosis referral center established in Brazil, and Dr. Waddington-Cruz faced several difficulties to create and maintain a multidisciplinary team devoted to amyloidosis. She participated in the development program for tafamidis, patirizan, vutrisiran, inotersen, and eplontersen, and served on several advisory boards and steering committees. Dr. Waddington-Cruz, she's the director of the research department of the University Hospital from 2019 until 2022, and is a permanent postgraduate tutor at the School of Medicine of the Federal University of Rio de Janeiro from 2013. She works together with the Ministry of Health of Brazil to write the guidelines for treatment of amyloidosis and to make tafamidis and other drugs be included in the role of drugs delivered by the public health system for amyloidosis all over Brazil. In 2023, she received the Grande Collar do Mérito do Tribunal de Contas da União for her distinguished services in favor of the Brazilian people, and I think we can all agree this is the list of the recognition she could get for all her efforts. So without further ado, I give the floor first to Dr. Elena Zamba to give us a very brief introduction to the situation in Cyprus in terms of patients, and then Dr. Marcia will guide us through the rest of the lecture in terms of treatments and in general for amyloidosis. So let's share. Okay. And now,
it's great honor for us to have Dr. Waddington-Cruz with us, and I would like to take also the chance to welcome her on this webinar. Cyprus and amyloidosis are related, and as
Let me help you.
Yeah.
Just press.
As we can see from this Europe map, Cyprus belongs to the map of amyloidosis in Europe. And as we see in Cyprus, we have a homogeneous population, and 100% of our patients, they all have the Val-30 variant.
Okay, we have.
This is the map of Cyprus, and in red spots, we can see the clusters of amyloidosis in Cyprus. We see that we have clusters in specific areas, in Kyrenia, in Limassol, and in Paphos. In these areas, we have very known medieval monuments. For example, in Kyrenia, we have the Bella Vais, it's an abbey that is from medieval period, belongs to Catholics. And also in Limassol, we have the Colossi Castle that also used to belong to the French that they were at that time the owners of the island. So the first families with amyloidosis in Cyprus were identified back in 1980, and the original families were counted to be 30. So we assume that the first patients arrived to Cyprus due to the Crusaders' excursions to the Holy Land, and possibly the red excursion with the red line that we see was started from France, Normand, passed from Portugal, Lisbon, Marseille, then from Sicily, Crete, to Cyprus and to Holy Land. During this third Crusaders' excursion, we all know from the Cyprus history that the King of England, the Lionheart, passed from Cyprus and he got married his fiancée. Possibly during this third Crusaders' excursion, people from Portugal got on board with the Lionheart towards the Holy Land, and possibly they left some of their genes in Cyprus, and that's why the areas that are the most are the clusters of amyloidosis in Cyprus. We see these medieval monuments that are related to this third Crusaders' excursion. So the first patients in Cyprus were identified in 1980, and until 2016, 82 Cypriots were genetically diagnosed, and as I told you, they were belonging to 31 families. We estimate the prevalence of hATTR in Cyprus to 3.72 per 100,000 population, whilst the incidence was estimated to be 0.69 per 100,000 population. The phenotype that was observed in Cyprus was mostly sensorimotor and autonomic neuropathy with neuropathic pains, and the cardiological manifestations were only seen in approximately 30% of the patients. We have late and early onset patients in Cyprus, and the mean age of onset was 46 years old. Recently, in data that we haven't published yet, we have seen that the prevalence has been increased, and also the incidence have been increased in Cyprus. Cyprus is a site center for clinical trials for amyloidosis. Since 2016, we were participated in the first Apollo treatment for patisiran, but also later on two clinical trials for Amvuttra and the Emlodersen with Ionis. The last data that we had last year, we have 30 carriers that they have the pathogenic variant, but still they are asymptomatic. We have 44 patients with familial amyloidotic polyneuropathy. The age of onset in 32 patients, at 73%, they are early onset patients with age of onset earlier than 50, and 12 patients, they have late onset at 27% with age of onset later than 50 years old. We have all the therapies in Cyprus. Last year, we had 15 patients on patisiran treatment, 3 patients on vutrisiran, and 3 patients in Odersen. We have also the oral treatments with tafamidis as a stabilizer. We have 4 patients with tafamidis 20 milligrams and 1 patient with amyloidotic cardiomyopathy with tafamidis 61 milligram. Now these numbers have been changed and we have much more patients, especially in vutrisiran. In Cyprus, we have also patients that they underwent orthotropic liver transplantation many years ago. We have long survivors, more than 20 years since the transplantation, and these patients, they are 27. So this is for Marcia, just to get know us. We are a small center compared to Brazil, but we have all the treatments for our patients. And also we have a team at our center that is follow up the patients. These patients, they need a multi-thematic care. So at the Cyprus Institute of Neurology and Genetics, these are the clinical trials that the Cyprus Institute of Neurology and Genetics has been participated in. And this is also a future trial that we will participate, okay? So SING is a tertiary referral center for amyloidosis in Cyprus. We have our team consisting of neurologists. Dr. Kleobas Kleoba is working on amyloidosis, Dr. Christodoulos Taliadoros, and Dr. Tassos Tsokos. We also have our cardiologist, Dr. Ilias Koutsoyorgis, who is seeing the patients here at SING. We have of the ophthalmologist, Dr. Kadia Papastavru, who is outside SING at the Pantheon Limassol Center. We have a physiotherapy unit. We have inpatient and outpatient services at SING. And of course, we do all the neurophysiological investigation. So this is what I wanted to say, just a small introduction about the amyloidotic community, I could say, of Cyprus, but also the care that we offer to the patients in Cyprus.
Thank you, Dr. Eleni. Yeah, that was very informative of what's going on in Cyprus. So now I'm going to stop sharing and Dr. Marcia can continue her lecture. And whoever has any questions can write it down at the Q&A and we can address them at the end. Thank you, Dr. Marcia. We can go home.
So I'm going to share my screen. I want to, first of all, congratulate the previous presenters. It was a wonderful presentation. I love to know about the history of hATTR in Cyprus. The last slide was fantastic, the white sand and the very blue sea. of course, I also like to thank you very much for this invitation. It's a very kind invitation. I'm very, very honored. For those, I received a long presentation, so I won't come to this presentation again. I'm very thankful also. It's kind of bioscat. But basically, I worked for many years in the center, so I'll try to present some of my experience. It's a lot to cover. There's a lot to cover. So I decided to make a small introduction on the disease itself, because I'm not sure about the audience, how much they know about the disease. And then I'll jump into what is more recent in terms of results for the different kinds of treatment available that we have nowadays. So hopefully it's... I cannot move my slides for some reason.
Try again,
Try
because
again.
I can see your slide.
Now it's going. So my disclosures, and I have permission to display some patient photos as well. So an overview of hATTR. As you know, TTR is produced in the liver. It's 98% production is inside the liver, but we need also to count on the 2% production that is inside the brain and inside the eye. It's going to cause problems in the future, and it's causing problems nowadays because patients are surviving more and more. And the function of TTR is to function as a carrier of the vitamin A process and thyroxine, but mainly of vitamin A. So whenever you try to knock down the production of TTR, you need to think about making a supplementation with vitamin A. And what happens is whenever there is a mutation or the process of aging in wild type forms, this tetrameric structure of the protein can become very stable and dissociate into monomers that will finally misfold and aggregate into C tissues as amyloid fibers. That's where we have the disease. So the presentation of the disease will depend a lot on the type of mutation, on the age of onset, and on the geographic location, as you was able to see during my previous presentation. But there is, this slide shows Professor Rapesi that we miss a lot from Italy. And he used to show us this kind of fan with the two poles of the disease. The V30M pole, with an early onset, that's mostly a neurological disease, and wild type form, or the 122 species variant that almost always presents as a cardiac disease. But let's see here that the V30M late onset mutation and case can present as a mixed phenotype. And we have several other examples of mixed phenotype. And sooner or later, during the progression of the disease, the patient will present with a multisystemic disease. As you can see here, we have ocular manifestations like glaucoma and some deposits. A lot of GI manifestations that are very trouble for the patient, for the quality of the life of the patient, with nausea, vomiting, diarrhea, loss of body weight. The nutritional aspects of these patients are really a big worry for us. And other manifestations of autonomic neuropathy as orthostatic hypotension, difficulties with the control of the bladder and of the gutter and so on. We are also very concerned nowadays about this 2% production of TTR inside the brain, and we are beginning to deal with dementia, seizure, and stroke-like episodes. In terms of the cardiac disease, we began with conduction blocks, with difficulties in arrhythmia, and then after we have the amyloid deposit in the myocity, outside the myocity, but inside the myocardium, and then we begin to have infiltrative cardiomyopathy. About the kidney, it begins with proteinuria, and then later we can have renal failure, and axonal type sensory motor, also autonomic neuropathy. It's just to give you a glance of the situation if it's not treated, this disease has a progressive and inexorable course to death in around 10 to 15 years. It's very interesting to know about and to have access to treatment, because let's think like this, only 5% of rare disease really have a disease-modifying treatment. And hATTR polyneuropathy is the only inherited neuropathy with disease-modifying treatment. So this is very important. This is very important for us to recognize those patients, to be able to treat them, because it's really not what happens in rare disease and in inherited neuropathies. So now I jump to the treatment. Here is a landscape of what we have nowadays, and it's rapidly changing. I will first talk about liver transplantation, so aiming to substitute the liver that is producing a bad TTR, but otherwise the liver is normal. The first liver transplantation was done in Sweden, I think in 1992 or 1993. And then 2005, we began to use the stabilizers, the tafamidis. The first trial began on 2005. More recently, we have the silence, aiming to knock down the production of TTR inside the liver. And after we talk about dual therapy, thinking about depleting the amyloid that is already deposited in tissues. So that's the landscape I will try to show you little by little. So as I told you, in 1992 or 3, first liver transplantation was done in Sweden. And shortly after, they were done all over the world. The first in Brazil was in 2000, not 2000, it was in 1995. And since December 2009, at least, they have, or even before, they began a registry in Sweden called the FAP World Transplanted Registry. We used to contribute with this small piece of paper that first we sent by fax, by courier, and then after by fax. It's unthinkable nowadays, but that's how we follow the patient and send to the register. How are patients, if they are surviving, if they are doing well on their clinical estimate, but it was something very modest, let's say, at that time. Well, after 20 years, they published the results. They run it mostly as survival analysis. You can see here the number of cases and how interesting the drop in the number of liver transplantations when tafamidis was launched in Europe in 2010, 2011. So in terms of general surviving, put everything together, early and late onset, V30M, non-V30M cases that are most, the prognosis is not as good as V30M. In 20 years, 55% in general, but much better for the V30M early onset patients. But problems related to liver transplantation. There are no, the availability of organs is not good enough for the number of patients. The mortality is still high and is still unpredictable in some cases, although we have learned a lot since 1993. But there is also morbidity related to the immunosuppression, of course, and progression that's not very important in the nerves, but it's very important in the heart for some reasons related to the mechanism of amyloid deposition. So whenever there is a previous amyloid deposition, the native TTR that's now produced by the new liver can aggregate and continue the disease. And also, of course, because of this 2% production inside the eye and inside the choroid plexus and the brain, we began to see patients that are surviving after liver transplantation much longer, and after the new treatment was also much longer. We begin to deal with the central nervous system and eye disease, different disease. That's why the first trial with this stabilizers, tafamidis, and then after diflunisal, but I will cover tafamidis because we don't have diflunisal in Brazil. So the stabilizer were aimed to, I will show you better after. They aim to bound to this tetrameric structure and prevent it to misfold, to disassemble into monomer and then finally misfold. So that's the theory. A lot is said about tafamidis, about the trial, a lot of criticism, but we need to understand what it was at that time. So tafamidis was the first drug to treat patients used to wait on the waiting list of liver transplantation. And then we're trying a drug, an oral drug. So it was really something that we suffered a lot of criticism. It was very difficult to construct the study design. There were no approved outcomes. They needed to use outcomes from diabetes. And they decided to construct the design, run a responder analysis and consider liver transplantation patients that left the trial to undergo liver transplantation as a non-respondent. And there was a kind of miscalculation of the number of drop-off. The number was subestimated, and it affected a lot the result of the trial. But I can witness this. Patients could not afford saying no when they are called for liver transplantation, as they were for a long time on the waiting list, and afford being on placebo, for example, for the first part of the trial, not knowing yet if the drug is going to be effective or not. So that's what I have to say. And then again, this is the commercial name, Vyndaqel, and it's in Brazil, and it links to this ligand sites of thyroxine, because the main function, as I told you, is the transport of vitamin A, retinol binding protein, vitamin A, and thyroxine. So it bounds and it prevents. That's what's thought, and at that time we thought that it would stop the disease, but actually what we saw was a decrease in the progression. Patients were randomized for the main trial, mostly with VICTOR-TM and stage 1. This FX005 was the pilot study with against placebo, and then after several extensions were run, and here I will present what Dr. Barroso from Argentina published as the longest experience with tafamidis in the trials in the open label extension. They used as efficacy measures quality of life, the fork that was considered for diabetes, modified BMI, because the nutritional aspect is a very important aspect of disease, as I mentioned, and a neurological scale, it's called NIS, neurological impairment scale, again, not considered for amyloidosis, so it underestimates the sensory aspects of disease, much more aimed to measure muscle strength and reflex, and only in the lower limbs, just to mention how different the landscape is nowadays. So as for the results, this is not a responder analysis, this is a different kind of analysis because it's the analysis of the open label extension. We can see here in the pivotal phase, in the first 18 months, the very different trajectory of the patients under the drug and under placebo, the change of the trajectory when they all enter into the open label extension. So although we see patients under tafamidis having a progression, this progression is not comparable to natural evolution of the disease. And we can see this change in the trajectory for patients that finally underwent the drug after 18 months of placebo, but they were never able to reach each other. So we really need to begin early the disease. This is about the same thing for quality of life. And this is the slope analysis of what would have been the trajectory of patients under placebo if they remained under placebo and not changed to tafamidis in the open label extension. This is a subpopulation analysis. I was the first author, where we try to study a population of patients with a very low NIS since the beginning. So patients really at the early beginning of the disease, and NIS less than 10. And we follow them for more than 5 years, and what we saw was a very slow increase. At the end, the increase after more than 5 years was around 10. And when we compare with the increase during the placebo phase of 4 points by year, it's really something different. So it's very important to start tafamidis as early as possible. So in conclusion, tafamidis delayed the neurological progression of the long-term V30M. There was a parallel study with non-V30M patients, and the results were not as good. The group was very heterogeneous. There was no placebo, as far as I remember. There is no placebo control. It suffered a lot of criticism, but it did something good in terms of quality of life and nutritional aspects. So I decided to focus on V30M. Early versus later initiation of tafamidis is, of course, better. And there is something that I can say a lot about tafamidis, that it's a safe drug. This is something that we are, whenever there is a problem with the kidney or with the liver or whatsoever, any kind of problem, we in practice, we sometimes, even if it's not the ideal moment, if the patient is in kind of late stage or is not responding as much as possible, we come back to tafamidis because it's really a safe drug that we can use in whatever circumstances. This is a photo of my dear patient. This patient is from Belém, but before, during the trial, she used to take a boat inside the Amazonas River, and they stayed in the boat, traveling the boat for more than 4 hours to reach the nearest city. I think it was not Belém, it was Santarém at that time. And then she took a plane, 4 hours of plane to come to the center to be a patient in the trial. She's still using tafamidis. She's doing very well because she was lucky enough, and I was lucky enough to be able to enroll her in the trial in the very, very early beginning of the disease. Then after, tafamidis was studied as the dose of 61 milligrams for cardiomyopathy. I was there. Our dear Ambassador Professor Rapesi presenting at the European Society of Cardiology in Munich. It was really a success, absolute success. And until now, it's considered the standard, the gold standard for treatment of cardiomyopathy related to hATTR. Then, 2015, the first generation of silencers began to be tested, aiming to reduce the production of TTR. So I will first present the results of inotersen, that's subcutaneous injection each week. The antisense oligonucleotide is delivered inside the nucleus. It binds to the RNA messenger that would finally produce TTR. It begins a cleavage process, and then there is a profound, very important drop in the production of transthyretin. This is the design of the study. I won't enter into a lot of details, just want to show you that both V30M and no V30M patients were included, different on the FXO5, on tafamidis. Both stage 1 and stage 2 patients, they were randomized 2-to-1 to receive inotersen or placebo, and then after they enter into an open label study, more longer. And I will present the results of both the patients that stayed on inotersen since the beginning and patients that were on placebo, then changed to inotersen after 15 months. I just want to show you that the most important endpoints that were used at that time and continue to be used nowadays for all the other trials are much robust than the knees, lower limbs that were used for the tafamidis trial. A lot of other exams were incorporated into the knees. So knees is mostly a reflection of a neurological exam, but knees plus 7 also use a lot of machinery, nerve conduction, QST, hATTR, so it's much more robust. It's very difficult to compare things. That's why I'm trying to say. And even modified NISPL7 that was used for, let's say, diflunisal trial and Alnylam trials and Ionis trials are very different. So that's how it's so very difficult to compare results and to try to put one drug side by side to the other. In terms of reduction of TTR, this is during the double-blind placebo, very different, placebo and the inotersen group. And after 50 months, they were all receiving inotersen, and we can see the important difference and the drop in TTR production. This was reflected in NISPL7. Here, the inotersen group, and here, the placebo group, and the change in trajectory when they enter the open label station, and the slope analysis of what would have been the progression without the active drug. But we can see as well that the patients that were on the placebo were never able to reach the same levels of NISPL7 as the patients that started early the drug. That's about the same for quality of life measured by Norfolk. And what was an important worry during the double-blind placebo phase, the 3 cases of glomerulonephritis, acute glomerulonephritis, and some cases of grade 4 platelet decrease. One of them that finished in cerebral hemorrhage and death because the patient was kind of lost to follow up. He did not came to the center. It was in Argentina to do the regular exams. So we had this fatal occurrence. But then after doing the open label station, short after this, a very strict control on platelets and on the renal function and protein expression, finished with no more events like this. But we really need to follow the patients that are using inotersen each 2 weeks with platelet counts and with renal function. That's the inconvenience. And some, of course, other site injection relations, a kind of flu-like sensation that was something that bothered us a lot during inotersen trial. So in conclusion, it was a fact up to more than 3 years of follow-up. And of course, if we begin early, it's much better, but we need to monitor platelets and need to monitor the renal aspects. A lot of patients were included. That's because it's very difficult for us in Brazil to have access after the trials to the drugs because of the price, because of the health system, the type of health system that is mostly public and not private. And 20 or more, less than 20% of the population has access to private health systems, or the patients that were very happy to take part in this inotersen trial, and also some people from my team. Patisiran was another silencer from Alnylam. And what you can see here is the mechanism of action. So patisiran is also a duplex silenced RNA, but it is delivered to the cell by a lipid nanoparticle. That's per se a very high development that was done inside MIT for several years to find the right nanoparticle lipid, let's say, mode of transportation to the drug inside the cell. The mechanism is a little bit different. It involves this RISC complex, but at the end, it finishes in targeting the MRA and cleavage in the messenger MRA, reducing a lot the production of TTR. Patisiran is an intravenous drug, and each 3 weeks, we need to make an infusion, and we need to have some pre-medication. I decided to show you a little bit different results because they also did a phase 2, different from the previous study from Ionis. They also ran the phase 2 open label. And this is the last presentation where they put it together, both the pivotal trial, Apollo, patients on a placebo and patients under active drug, and the phase 2 patients that were exposed to the to inotersen, to patisiran for a much more longer period, 6 months. And I'll try to present you to compare the patients that were under patisiran for a longer period, patients for long but less long, and then patients that changed from placebo to the active drug after the open label extension. In terms of NIS+7, we can see the results, very different results from the placebo and from the active drug. And although they also change the trajectory, they were never able to touch each other to reach the same level of response. And for the first time, a survival analysis was run at Kaplan-Meier, and we can also see that's the very different progression in terms of survival for the patients that were under active drug since the phase 2 or since the Apollo, that were lucky enough to be on the active drug, and the difference from the ones that were under placebo, although they changed after the entrance into the open label station, they are never compared. In terms of safety, we are not really very worried about, except the fact that the patients need pre-medication with steroids, and this is something that we don't want to keep for the life. I have some problems, of course, but compared to the effectiveness of the disease, it's something that we need to consider. And also some infusion-related reactions that we need to manage, but that are very manageable. So in conclusion, patisiran was super effective in terms of neuropathy progression, of survival, and we can deal with also the run ambulatory function analysis that I decided not to show in the interest of the time. If you can make a brief at this point, liver transplantation aims to replace the production of faculty hATTR. The benefits, it has a good impact on survival, most important for early onset and VTM, but limitations, limited supply of organs, risk of surgery and immunosuppression, progression of neuropathy, and most important, progression of cardiomyopathy and of abnormalities related to central nervous system and ocular manifestation. But I need to say that this is equal for all the drugs. Even with the second generation of science, we don't have a drug that can, except from tafamidis, that can cross the blood-brain barrier and do something with the central nervous system. Even tafamidis cannot cross in a level that is effective. But that's a problem that we have for all the, so we need to be fair enough. It's not a limitation of liver transplantation, but of all the drugs. Whereas for tafamidis is a stabilizer, it decreased the progression of neuropathy in stage 1 VTM, has an excellent safety profile, but it's not good for stage 1, stage 2, and I would also want to say that it's not good for late stage 1. Stage 1 is a big stage, it's a very long stage. When the patient is in PMD2, is already in late stage, I would prefer to use another drug, depending on several other aspects as well. Patisiran prevent formation of TTR as a silence as well as an inotersen. One is an infusion, other is subcutaneous injection. Both can stop the progression of the neuropathy or decrease a lot the progression of the neuropathy in both stage 1 and stage 2 VTM and no VTM. One requires a pre-medication, patisiran, and there are some infusion-related reactions. For the inotersen, it's a subcutaneous injection, so it allows me to treat patients all over the Brazil. Let's say I follow patients in North Brazil, South Brazil, but we need to closely monitor renal function and platelets. It's something that is also very complicated to keep on real life for a long time. That's why both sponsor came with the second generation of silencers. So basically, a GalNAc complex was created with the main drug, with the oligonucleotide, aiming to a much more effective delivery of the drug inside the cell, and the target delivery reduces the systemic exposure. So, and the efficacy is also much longer, much bigger, allowing us to do a less frequent dose. So it's a subcutaneous injection for eplontersen, let's say the second generation from Ionis, only a monthly injection, and we don't worry anymore about the kidney and about the platelets. The design of the study was a little bit different because at that time we had tafamidis approved and even other drugs, so it was impossible to run a trial against placebo. They used the historical placebo control group from the previous study, and also some of the patients were randomized to receive eplontersen. After a while, they all were receiving eplontersen, and so they were able to compare eplontersen with the historical placebo and eplontersen with eplontersen, using basically the same endpoints, hATTR, Norfolk quality of life, and misplacement. I just want to mention that they were very encompassive, as in the next trial, including both stage 1, stage 2, VTTM, no VTTM, patients that previously used stabilizer not, and patients with cardiomyopathy or not, and also patients from all over the world. As for the TTR reduction, very important, very big difference compared to the historic placebo, and this was maintained in this extension analysis up to 85 weeks. And in terms of misplacebo and Norfolk, also a very different situation in terms of evolution. And even we can see here, let's say, a more important benefit after 85 weeks, and about the same for Norfolk quality of life. So we are absolutely convinced about the efficacy of the drugs and about the effect for the quality of life of the patients. In terms of adverse events, as I told you, we are not worried about vitamin A because the patients receive supplementation with vitamin A, and there was no worry about glomerulonephritis, no cases, and no problems about the platelets, and even the very convenient flu-like symptoms of that were started by the injections. We don't see these anymore. So we are really very, very happy to have a new drug that's more efficient, that allows us to inject less frequently, and we are no more worried about the platelets and about the kidney. Of course, we were still controlling, but not worry. This was the challenge of running the trial. Some of the patients, because I have a lot of patients during the pandemics. And then the EUS study from Alnylam was also a second generation of silence. The same GalNAc complex was aggregated into patisiran, and we have now vutrisiran. That's this new platform drug that allows for injection, subcutaneous injection, once injection in each 3 months. This is something that really is very nice to live to see how this progress. Patients are taking 4 injections in a year. And it was kind of the same design. Patients were randomized 3-to-1 to receive vutrisiran or the reference group patisiran, and they also used this historical placebo group from Apollo and used the as primary endpoint misplacebo and several other exploratory analyses. Don't want to enter into detail, just again to mention that there was no criticism about the population. The population was very competitive, VTTM, no VTTM, different needs. So patients really under severe disease since the beginning, several different ambulatory capacities, and even a cardiac subpopulation. And in terms of NIS, let's have an Norfolk evolution, very stark difference between placebo and vutrisiran, in terms of quality of life, and in terms of drop in TTR production. Here we can see that vutrisiran has a comparable drop in TTR compared to patisiran. So we can, we're very pleased to see that we can substitute the each 3 weeks infusions to each 3 weeks subcutaneous, each 3 months subcutaneous injection, something that's in the daily life, in practical life, for young patients that work and would take this drug for the rest of their lives, something that's very important. So that's just a brief of what I have just said. Again, patients very, very happy. Let me mention this patient was kept alive with tafamidis since the start of the trial. But of course, he progressed his neuropathy, but was kept alive, and he was able to be enrolled into the vutrisiran trial. Now I'm much more confident about his future. So just to make you a final comparison, brief of everything that was said until now, I noticed in the silencer, oligonucleotide drug that is approved for polyneuropathy in US, and it's approved also in the Europe for both stage 1 and stage 2, as well as patisiran. That's not an oligonucleotide, but it's a interferon RNA drug. Same regions of approval. One is subcutaneous each week, other is intravenous infusion each 3 weeks. It's self-administered, the other is not, of course. There's no premedication required, it requires premedication, but you need to follow renal function and the platelets very closely. And there is no target hepatic delivery. It's different from the second generation. It's about the same thing, but because of the target delivery, we're able to reduce the frequency of the injections or the infusions. Nowadays, actually, it's both are subcutaneous, and one is delivered each 3 months, other is delivered once by month. Vutrisiran is not self-administered, but I think it could be. It's just because the fact it's a recommendation to be administered by health professionals, because it's just once each 3 months. So if there is something wrong, if the patient missed the drug, this can happen. They are not very nice with the hands because of the neuropathy. So something happens. So there is this recommendation of using the health professional to administer the drug, but in other aspects that are very compared. And as for the tafamidis stabilizer, it's approved for cardiomyopathy in US and in Europe, and for polyneuropathy only in Europe and only for stage 1. The more recent guidelines recommend for polyneuropathy guidelines from both cardiac societies and neuropathy societies and amyloidosis societies. It's the ever-changing process, but so far is this for polyneuropathy stabilizer. If the patient is stage 1, it's beginning the disease. It depends on the availability of the drug of the country, and if the patient is on stage 2 or is not responding to the families, then a silence. If it's a cardiomyopathy and wild type, is a stabilizer so far, because we're waiting for the ASB and if the for the cardiotransform results. And if it's a variant type and it's mostly cardiomyopathy, a stabilizer, but if it's a more mixed phenotype, you would prefer a silence. And what I see, at least in US a lot and in Europe, is a combination of drugs. So because the patient is on a silent does not mean the patient will stop using tafamidis, at least this in commercial use. And for the future, the next steps, we are running trials with CRISPR-Cas technology that aims to edit the gene, and it would be a one-time life injection that will suppress the production of TTR. We wait a lot from this. Some previous results were already showed, and a dual therapy, a depleter therapy, aiming to remove the amyloid that was already deposited. We are seeing the results from the preliminary results from the first trials with the monoclonal antibodies. There are several ones. So I've talked a lot, and I thank you very much for your attention. And that's the Iguaçu Falls that I had the chance to visit last year. Thank you very much for your attention.
Thank you, Dr. Marcia. That was a very detailed and very helpful, I think, presentation. And it's amazing to go through the history of how the treatments progressed from the very beginning. And now we are facing like a one-time injection that may help these people, because it's so detrimental what is happening. So thank you very much. It was wonderful. We have some questions that we can go on and read them. So, okay, we have from Dr. Pani Trifilis. Congratulations, Dr. Elena Zamba Papanicolaou, for an amazing presentation on a very interesting overview of hATTR and the community in Cyprus. It's wonderful to see that you and your team provide such excellent care and treatment to your patients in Cyprus. Congratulations again. So we have a question along with the congratulations to Dr. Zamba. So the question is, are all patients followed at the Institute of Neurology, or are they cared somewhere locally?
No, the referral center for this disease is the Cyprus Institute of Neurology and Genetics. We have the experience, and we have the multidisciplinary team. So yes, to have a holistic approach and a better management of the patients, we follow up the patients here.
Okay. And then another extension to that question is, how easy is it to assess rare disease drugs for your patients?
As Dr. Waddington said, this is more a governmental policy to approve and have the newer treatments. In Cyprus, we are lucky. We had a problem at the beginning to approve and have the tafamidis, because the first patients had the tafamidis treatment in Cyprus in 2014. So it was rather late, and unfortunate for some patients that they underwent liver transplantation after 2010 until 2014. But nowadays we have all the silencing treatments available. Of course, we have to do an application, and they all have to pass from a committee in order to approve the medications. And in Cyprus, we have to prove that they have amyloid deposit. We need either a biopsy result, or we need NDPD heart amyloid deposit with a DPD to show that there are amyloid deposits in heart. So, or perhaps in the eye and deposit. So this is how we do it. We need to prove with a biopsy that we have amyloid deposits. And we could say that we do not face problems to start the patients, the treatments. We do have some problems, though, for the transplant patients. Now we're facing a problem because some of these patients, they are now progressing to cardiomyopathy, who have approval for the tafamidis 61 for these patients. And the reason is because there is not enough data or a consensus criteria for the cardiac management for these patients. So we have a problem on this, though I know that in other countries is well accepted, and the tafamidis 21 is the medication of choice and for these patients also. So yes.
That's difficult. So we have also a question or congratulations to Dr. Marcia from Dr. Trifilis. So congratulations, Dr. Marcia. What a comprehensive overview of hATTR and the treatment options available. A huge thank you for your sharing your deep expertise on this subject with the community in Cyprus. Your dedication to patient care and the advancement of treatments for patients across the world, even for patients in Cyprus, is admirable. So thank you. I think it extends our own thank you to us. So I have a question, I guess, to both of you. So I was wondering if there was ever a person that had the mutation or a mutation to develop amyloidosis or the family of this disease, but never went on to develop like the serious symptoms like irregular patients. Was there an outlier or one of those people that they are resistant? They have some resistance gene. Has this ever been observed in the literature? So
yes, so at least for hATTR, we are very sure about this. We ran some studies together with Dr. Violaine Planté from Rimondor in Paris, and we know that the penetrance of the mutation is not complete, and it reaches around 80% at the age of 80, after the 80s, and begin to increase a lot after the third decade of life. So patients around the 30s, they begin to be more in risk of developing the disease, but it will be 80%. So at least 20% of the patients will never develop the disease. Our second mutation, that is 122, that's mutation from African origin, that leads to a much more cardiac disease, and sometimes in patients we have both. The penetrance is much lower. It's around 40%. This is actually a problem nowadays because patients are running exomas and very complete panels, and even child are detecting positive mutations, the presence of variants, and there is a chance, at least for some of the mutations like 122, that they will never develop the disease, but we need to follow them. So yes, some patients will never develop the disease, although for the most common mutation, that is V13, the penetrance is very high.
Okay, and
the same also in Cyprus. We have around 10% of the patients of the carriers of the mutation that they never developed symptoms. But the last years we have seen cases that they have very late onset. So perhaps this depends on the life expectancy, and is changing. Yes. Yeah, the longer we live, perhaps this is changing. Okay. So around 10% in Cyprus also, they remain carriers until the end of their life.
Oh, that's hopeful. So and also, are there any lifestyle changes or modifications that can help control the symptoms? I mean, on the side of whatever medications these people are taking. I know we're talking about neuropathy, and that's a very difficult thing to manage in any site it is. But are there any things that people can do to aid a little bit in how the symptoms progress?
We know that there are a lot of epigenetic factors involved in the manifestation of disease because, for example, we have some twin sisters, monozygotic twin sisters, develop the disease in different ways in different ages, and even inside the family have some anticipation. but I'm not able to say that one single thing can be done in terms of health, in terms of living a healthy life that would make the difference. Of course, we recommend a health way of living, so as for all the disease. Of course, this is important for the GI manifestation to keep a right diet and etc. But we cannot say that one specific thing can be done to change or to influence the genetic mandatory aspect of the disease.
Dr. Elena, you have anything
I
to
agree.
add?
Yes, I agree, fully agree. But it is important, though, the early detection of symptoms, because what makes really the difference is the early initiation of treatment.
Absolutely.
So I guess that I mean, you know that if it runs in the family, people will test.
Yes.
But is there any other way for people that don't know that they're carriers? I mean, what are the warning signs? I mean, I understand them, they might differ between mutations, but are there any general outlines that people should be aware of that might be helpful? Because I know there might be people that are listening to us now that might be, this will be useful to hear.
If they have a family history, it's much less complicated because they can be tested and they can be followed in a center each 1 or 2 years and run a battery of tests. And if they experience any symptom related to neuropathy, some sensation of abnormality or GI manifestation, they can come to the doctor and run tests again and they will be detected. It's much more complicated for the general population, let's say. This will be in charge of the doctors. It's to be medical education to teach them how to recognize the red flags. Sometimes they come from an echocardiogram. Sometimes they come when they are investigating a neuropathy of a no cause, but it's difficult for the population itself to recognize and target the disease. Otherwise, they will be worried about any diarrhea or any small sensory complaint or carpal tunnel syndrome. That's something that is very frequent in the general population. That's my point of view. I don't know.
Yes, I fully agree. They are so general or common, the symptoms, like from the gastrointestinal or from the heart or so. But I think that the health professionals, they are more aware of the disease now because of the treatment. The disease got more publicity. So I think that it is important from the point of the health professionals to recognize the first symptoms and refer the patients to the centers for diagnosis and management.
Okay. We have a question for Dr. Cruz. So it is amazing to see that there are multiple treatment options for these rare diseases patients. From talking to your patients, what are some of the limitations of the current treatments and what are they looking for in a future drug?
So the most important limitation is access to the drug, because I showed a lot of patients that are inside the trials, but when they are outside the trials, in Brazil at least, they only have access to tafamidis 20 milligrams for polyneuropathy. If they want to have access to all the other drugs that are already approved, except for eplontersen, that's on the way to have the approval, but not yet because it was the last trial, they have to sue the government or to sue the health providers to receive the drug. It's a hard way to receive the drug. It's not a good way to receive the drug. So that's the most important limitation. But let's say if they are at the early beginning, they can have access to tafamidis, or if they're not responding to tafamidis, then they will need to move and to sue the government or to enter into the clinical trial. But what are the gaps? I think the gaps are around the world. It's the central nervous system. We need to find a drug that will be able to act on the central nervous system production, and in the eye production. of TTR. We also need to find drugs for more late stages. Maybe the depleters that will remove the amyloid that was already deposited. And still we have patients that don't respond to any of the drugs. But now we are very happy to have a stabilizer that is safe, and it's available and can be used as soon as possible. Very soon we will also have this for cardiomyopathy. And then we would be able to use the second generation of silence and even the depleters in the future, but the problem is the access.
Yeah. And in terms of I remember at the end you presented a monoclonal antibody
Yes.
that's being developed. So that would be something that would be one time. Is that the prospect of it, or different times?
We don't know yet. They are under investigation. So the first results were on the cardiomyopathy, and we can see the amazing photos of the scintigraphy showing that the tracer is much less much less tracing my amyloid. But we don't know yet for the future when the trials are finished how they will be recommended as a month infusion, or they will be tracking if there is no more amyloid and then no need to. We don't know. It's still on the trial.
Yeah, and I guess the brain also is the last frontier because you have the brain barrier there. And it's the same with with brain cancers, because you don't have access to the brain due to the barrier. It's very difficult to treat some brain cancers due to that. So maybe there's a interaction of the two fields that one can learn from the other and can help with that. So I don't know if Dr. Eleni has a comment or question.
No, I agree. Dr. Waddington said that the future challenge and the bigger challenge is the later on complications of the disease, that they are the brain and the eye complications. This is the challenge of the treatments, and we need targets for the CNS manifestations and the eye manifestation.
That's the last frontier.
Yes.
Yeah. So I don't want to take up your time, but my last, I guess, request for both of you, being experts on one in the other one end of the world and on the other, is what would be your take-home message for people and I guess specialists hearing you now? Like, what would be, what would you like to leave as a take-home message? Closing this conversation.
I would say that for doctors to get interested in the disease, because it's a treatable disease, as I show you, it's a rare disease, but it's among 5% of the rare disease. There are a lot of rare disease that we can treat and really modify the life of the patient. We need to fight for treatments to be available for all our patients. We need to detect the patients as early as possible, because it really makes a difference. And for the patients, whenever they have a history, families get tested and get followed. The landscape completely changes. It's not like it was for your grandparents or your parents. Nowadays, we can really do something and modify your life. And I think that's it.
Yes, I agree also. Yes.
So I would like to say
a big thank you.
Yeah, a huge thank you for accepting the invitation and for being with us today. Thank you to Dr. Eleni for also being with us today. And thank you to the people who have stayed with us for so long. Thank you again. And we really hope to see you in Cyprus again.
Yes, me too.
Repeat this live.
Me too.
It was a pleasure. Thank you very much for accepting the invitation and kickstarting the new season. Thank you very much, and thank you.
Thank you very much. It was my pleasure.
See you.
Bye.
Bye bye.